Good afternoon. I know things have been running behind, so hopefully we'll get some more folks coming in here, but I appreciate all of you who are here, and appreciate also the warm hospitality here in Turkey. The presentation I'm about to give is about the survey that we collaborated on around risk factors for substance abuse in Turkish youth. And first I'd like to give a little background in general about risk factors in adolescence for substance abuse, and then go into the study itself and some of the initial results. Okay. So obviously when we're talking about drugs and alcohol, it's important to note that we don't just refer to illicit drugs, which are the obvious ones, marijuana, cocaine, opiates, etc., either ones that are illegal or ones that are illegal to obtain without a prescription or a doctor's recommendation. But we also look at cigarettes and alcohol. And cigarettes and alcohol may be legal, but they are, in the United States, they're legal for adults over 21, and they're considered, along with cannabis, gateway drugs, i.e. they are the on-ramp on which people get on in beginning their drug use and then progress into deeper and more significant drug abuse. There are a number of surveys that have looked at youth trends in substance abuse. Probably one of the earlier surveys is Monitoring the Future. It's been around for close to 30 years, conducted by National Institute of Drug Abuse. It covers high schools and junior high schools in the United States annually. There's also now more recently the National Household Survey by the Substance Abuse Mental Health Administration. It's an annual survey of substance abuse and mental health, both in youth and adults, but in households. SPAD and Youth in Action are two European surveys that have patterned after the Monitoring the Future survey and have begun to look at trends in data amongst European youth. The trends in the United States are that we have approximately 1.7 million new users per year over the age of 12. So this is a very significant problem. Lifetime prevalence of any illicit drug is 25% for 8th graders and 44% for 10th graders. We'll see in a minute how that differs with Turkish youth in Istanbul. The highest rate of use is in the northeast United States, and the lowest is in the southern United States, but it's all pretty close in terms of about use in the past year being in the 40% of any substance by youngsters. And the lowest prevalence is actually amongst African Americans, with Latinos, Hispanics the highest for cocaine and crack, and the other substances amongst pretty much the same, with one exception: major alcohol abuse in American Indians. That is a major problem that we've had in the United States for some time. The risk of substance abuse peaks in the United States at ages 18 to 22, declines after age 25, except for cocaine, which actually peaks later. And those using before the age of 15 are at the highest risk, i.e. early users usually have higher risk for substance abuse and also addiction. Substance abuse or substance use disorders is associated with many risky outcomes. Violence, sexual promiscuity, sexually transmitted diseases, including HIV/AIDS, motor vehicle accidents, mortality from overdose, but also mortality from suicide, and sometimes those are hard to tell apart. School failure, depression, or again, some of just many of them. And as I mentioned, the gateway substances, cigarettes, alcohol, and cannabis, are the ones that we also keep track of, because they are the means through which youngsters get introduced into using substances and then progress into deeper substances. You can see the progression even for cigarettes, half a pack, 2% for 8th graders, and by the time you get to last year in high school, 9%. In 30-day prevalence use of tobacco, 27%. Daily alcohol, 0.7% for 8th graders, and then 3.5% for last year in high school. 80% lifetime use, 50% the last 30 days. and 60% to inebriation. And daily marijuana use, 1.2% per eighth graders, and all the way to 6% for seniors. We need to recognize also that adolescence is a particularly vulnerable developmental stage. And it's also a developmental stage that is governed by both biology and also culture and cultural environment. It actually didn't even exist or was recognized in the 1600s in Europe. Before that, many cultures didn't even have a period of time that was adolescence. Basically went from childhood to adulthood, and you went through some form of maturation ritual. The emergent class in the Italian city-states probably introduced that first, and then it began to extend through the Western world and progressively throughout the world as we had greater urbanization, better economic conditions that allowed the leisure of having an adolescent period where you transition from childhood to adulthood. Globalization, though, has contributed to a worldwide youth culture. And that obviously includes fashion, music, social media, many times substances being very much associated with those. And still, substance abuse is still very linked, adolescence is still very linked to socioeconomic status. In some ways, for the poor around the world, there still isn't much of an adolescence. Adolescence has a very significant physical component. We obviously know about puberty and both sexual maturation and linear growth. The onset of puberty has an impact neuropsychiatrically on the pruning of neurons, and that may even leave some youngsters vulnerable, both even to mental illnesses, but sometimes even to faulty thinking and impulsivity. Their firm pathways for judgment are not quite established as a result of the reduction in redundant connections. However, puberty also leads to linear growth and sometimes leads to a false sense of maturity for many adolescents. Psychosocially, we know adolescence is a stage where youngsters are involved in conflict with their parents, to some extent of isolation, and turning inward and self-exploration, peer over-identification, sometimes just with a group of friends, sometimes even with gangs, and seeking out role models in older peers, which sometimes can be problematic, sometimes with adult mentors, which can be perhaps turn out better depending on the adult mentor. And much experimentation with different behaviors and friendships. The reestablishment of closer relationships with parents doesn't come till later. The humorist Mark Twain in the United States used to say, my parents became wiser the older I got. And obviously that was the perspective of the adolescent. We know with adolescence, though, comes a very significant impulsivity and mood lability and engagement in risky behaviors, both as a result of problems with, abstract thinking, problems with judgment, with limited development of the prefrontal cortex, and adolescents often need external limits, but sometimes rebel against them as well. And it takes them a while to develop internal mechanisms of self-control. So obviously all those factors put them at risk for substance abuse. And many adverse environmental factors contribute to adolescent substance abuse: poverty, abuse and neglect, family chaos or role malfunction, parental mental illness, parental substance abuse, parental criminality, multiple losses in the family, exposure to violence, both at home and in the community, the peer culture and media, as I mentioned, and even acculturation stress in immigrants and minorities. And this is just a schematic that lays out how many of these factors interact, the biological, genetic, even risk for mental disorders, the environmental stressors, interplaying, and then interplaying with the choice of drug, either route of administration or early use, and then the impact on brain mechanisms, and ultimately the impact on addiction. Now, addiction tends to come later, tends to come into early and middle adulthood. So in adolescence, you don't see as much addiction per se. In the context of this, a group of us had the honor of being able to collaborate with colleagues here in Turkey and look at data from a survey that was conducted in Istanbul and the various provinces that comprise Istanbul. The Istanbul Department of Education and Istanbul Police Department, the Istanbul Section of National Police, were the ones that conducted the survey with permission from the government of Istanbul. And this is a survey of a representative sample of Turkish high school students. The aim was to develop models to understand risk factors of substance abuse and associated psychological problems in Turkish youth. The data set included a recruitment of 31,000 students, representing 20% of the total high school population. I left that out here. 28,000 actually responded. It was conducted from May to June 2010, and it was according to the Helsinki criteria with appropriate, legal process. This is an anonymous survey. All responses are protected, and it went through our own institutional review board in the United States at Cooper Medical School. Out of 39 provinces, 28 in the inner cities were selected. The schools included sampling from the regular occupational non-Anatolian high schools. So we ended up with 65 regular, 62 occupational, and 27 Anatolian high schools, so proportionate to their numbers overall in Istanbul, representing 20% of the school populations. And within those high schools, then, the classes there was a stratified sampling to include grades, level, gender, age, etc. Ninth grade is the largest study group, and student numbers decreased the higher the grades that were sampled. The survey instrument was actually a combination of the European Survey Project on Alcohol and Other Drugs, i.e. SPAD, and the Youth in Europe survey. So it's an amalgamation of both surveys. Both have been translated to Turkish and have been used in research previously in Turkey. We included a trick substance called Relevin for the youngsters to select if they were confabulated about the results. Those who selected that substance, their responses were taken out as being not being credible, and this only consisted 1.2% of the sample. These are the substances that were surveyed. I won't go through every one, but it's a pretty comprehensive list, included even homemade brews. And these are the variables that we looked at in some of the instruments. Obviously, age, gender, school type, family immigration status. Here we looked at whether the youngsters had lived in the city, and both parents lived in the city, or there were families that had emigrated from the rural area, or were perhaps of a mixed background. Some have come from the city, some from more rural. Perceived family affluence about the youngster. Parental education, total years of paternal and maternal education. School grades, how they performed in school. Self-esteem, we used the Rosenberg self-esteem scale. We had a faith scale to look at religious, spiritual faith. Anomie, we looked at through the anomie scale of exteriority and constraint. Anxiety was a scale that was included with anxiety items, and we developed a total score. We used the Centers for Epidemiological Studies depression scale, with very time-tested measure for screening depression. An item on suicidality in the past week. An irritability and anger scale, antisocial personality through the antisocial behavior scale by Bachman. And then we also looked at a number of other variables: time with peers, time with family, involvement of the parents, family substance use, and peer influence. The data that were already comprised by certain scales, where the scales were scored, but obviously for many of the other categorical variables, we just developed a tabulation process to give a higher value to the higher category, a lower value to the lesser category, and totaled up the total numbers. We used t-tests and chi-square statistics to analyze group differences, but we also used binary logistic regressions to analyze regression models with dependent variables, i.e. the substances being primarily dependent variables, and many of these other risk factors as independent variables. And the level of significance was kept at less than 0.05. and we looked at model coefficients and R-square values. In terms of raw data, first off, out of our 28,303 responses, lifetime use of cigarettes was 45.5%. Alcohol lifetime use was 32.5%. Marijuana was 3.3%. Illicits outside of marijuana were 9.2%. That meant using any illicit outside of marijuana. Polyuse, i.e. using any two illicits except for cannabis, was 724, or 2.6%. Now, we tried to look at data for what we call heavy poly users, folks who had used over 40 times a year of alcohol or cannabis and over 20 years of illicits. We only came up with 19. That would meet my criteria definition for dependence or very serious abuse. So as you see, very, very, very few of the youngsters met criteria, but many of the youngsters in the less severe categories are certainly beginning to be on their way. These numbers may be a little hard to see, but I can summarize them. I can summarize them quickly. By school type, actually, the cigarettes had the highest percent in vocational schools, alcohol with the highest percent in Anatolian schools, and marijuana had the highest percent in vocational schools. And that is respectively 49%, almost 50% for vocational cigarettes, 39.7% for alcohol and Anatolian. This is lifetime use, and 4.1% for cannabis in vocational schools. School type and age of first use. Actually, the earliest age of first use was in the Anatolian high schools for tobacco, and that's the highest percentage, 5.4%. If you look at age of first alcohol abuse, again, that was true for Anatolian schools at 6.2%. That's age 11 and before. Then in Anatolian schools, pretty much having the highest use of alcohol of any of the age groups of first use. And school type and perceived number of friends using school, the highest percentage, i.e. many and almost all, was in Anatolian high schools. And the school type and perceived number of friends using marijuana was also in vocational schools. Those are pretty consistent data, because actual friends use sometimes is a proxy for your own use. So it's pretty good consistency between what they see their friends using and what they're using. These are logistic regressions that we ran for various substances. First, for alcohol, the model is a fair variance that explains 12 to 23% of the variance. In the model, the significant variables for tobacco include age, parental education, anomie, antisocial behavior, irritability or anger, time with peers, time with family substance abuse, and peer influence. For alcohol abuse, the model was actually stronger. It was actually explained somewhere between 22 and 34% of the variance, and it included many of the risk variables: age, immigration status, income, depression, anomie, antisocial behavior was marginal, suicidal ideation was marginal, irritability and anger, time with peers, parental involvement, family substance abuse, and peer influence. The regression model for cannabis was a little weak. It's got kind of a broad range, between 4.5% and 24%. The two R-square measures are a bit divergent, and we have to look a little more at why such divergence. A narrower set of risk factors: age, anomie, antisocial behavior, family substance abuse, and peer influence were the risk factors that are most associated with cannabis use. And for illicit drugs other than cannabis, Again, a modest predictive value, 0.6 to 13% of the variance, 6 to 13% of the variance, and the variables were age, immigration, depression, anomie, antisocial behavior, irritability, faith, parental involvement, family substance abuse, time with peers, time with family, peer influence, grades, and suicidal ideation. The last of the regression analysis here, again, a bit divergent, 5 to 25% of the variance, was a lot narrower. Antisocial behavior for polyuse, suicidality, irritability, family substance abuse, and peer influence. And I'll skip the here. So, for lessons and conclusions, we felt that for the gateway drugs and even for the illicit drugs, a number of important variables came up as significant. And I've listed the ones that we felt were more significant here. Demographics, primarily age, socioeconomic status, as reflected by parental education, income, and school type, culture, which reflected by immigration and school type, psychopathology, which includes depression, anxiety, and suicidality, psychological distress, as reflected by anomie and irritability, anger, peer influence, including time with peers and peer influence measure itself, family influence, time with family, and also family substance use. And particularly that is a bigger variable even when you look at polyuse. Antisocial traits, faith, or actually lack thereof, grades, are other significant variables. Now, obviously, one cannot assume these are causative. You have to look at this as correlational, but it certainly can give you profiles of the types of youngsters that could be identified for broader preventive interventions. You can say somewhere between primary and even secondary interventions. However, for true secondary interventions, secondary prevention, for heavy users and polyusers, psychopathology is reflected in suicidality, psychological distress is reflected in irritability and anger, antisocial traits, peer influence, particularly family substance abuse, are the key variables. And here you begin to identify the group of youngsters that is more on the way to significant histories of substance abuse and addiction. And again, these are correlational. You can't see them as causative, but they certainly could help to create profiles to identify youngsters. In conclusion, I think this data can point the way to some targeted prevention efforts. Primary prevention focusing on gateway drugs, secondary prevention and treatment focusing on youth at risk of more serious use, particularly in the youth engaging in polyuse. Schools and families are important partners, and I think psychoeducation in the schools is particularly important, particularly psychoeducation that addresses psychological risk factors and offers alternative to youngsters other than substance abuse and as a means of coping. Family psychoeducation through the schools. I really think ultimately the schools are an institution that families respect, and family sees as very important for their children's success here in Turkey and really and most parts of the world. And there's a great opportunity here through the schools to educate parents on how to effectively deal with this risk with their youngsters. Using cultural strengths. I'm a great believer in using the strengths of a culture and cultural belief systems that are protective. And their families are important, positive traditional beliefs, but also in the context of destigmatization discussion about the topic. Sometimes culture can stigmatize a bit, and I think that's the part of culture that we have to perhaps counteract a bit and have a more open discussion about these being significant problems for youth rather than being in denial. So I see a very bright future for the Near East, and I congratulate you all on your interest in this topic. Thank you.